rapid access to comprehensive oncology data and survival analysis. This is the Enko Toolkit.
You've got a patient with metastatic renal cell carcinoma. You need to stratify their risk, and you need to do it fast, accurately, and based on solid evidence. Let's see how you can get that done in just a few seconds. Okay, so what's the core challenge here? It's that immediate clinical triage moment. You have to categorize your patient's risk to figure out the best path for systemic therapy. Now, doing that manually, well, you know the drill. It means juggling multiple guidelines, checking criteria, and all of that takes up precious time. This tool is designed to automate that entire workflow. But before we even touch the software, let's get into the science it's built on, because that's what really matters. We're talking about two foundational prognostic models. First, the modern standard, the International MRCD Database Consortium score, which you probably know as the IMDC or Heng criteria. And second, the historical benchmark, the Memorial Sloan Kettering Cancer Center score, or the MSKCC/Motzer criteria. Now, here's what makes this tool so powerful. It doesn't force you to choose. It calculates both scores at the same time. So you get the IMDC model, that's the current NCCN-aligned standard of care, really built for our modern era of immunotherapy and targeted agents. But you also get the MSKC score, which provides that crucial historical context, especially when you're looking back at older clinical trials from the cytokine era. So what's the difference between them? Let's just break it down. You can see they share 4 core risk factors that really give you a snapshot of the patient's overall health and how aggressive the disease is. We're looking at a Karnofsky performance status under 80%, less than 1 year from diagnosis to needing treatment, anemia, and hypercalcemia. But the key distinction lies in those other parameters. The modern IMDC score adds in neutrophilia and thrombocytosis, really important inflammatory markers. The older MSKCC score, on the other hand, uses high lactate dehydrogenase, or LDH, as its marker for cell turnover. And what does all of this actually mean for your patient's prognosis? Well, this table lays it out perfectly. For the IMDC model, if you have 0 factors, that's favorable risk, and we're looking at a median overall survival of 43.2 months. 1 to 2 factors puts you in the intermediate risk group at 22.5 months, and if you have 3 or more factors, that's poor risk, with a median overall survival dropping to just 7.8 months. And right there, you can also see the corresponding historical data for the MSKCC model. This is the peer-reviewed science that the calculator brings to life. All right, so we've got the science down. Now let's see how the tool translates all of that theory into an instant, actionable result you can use right at the point of care. The interface, as you can see, is incredibly streamlined. It's built for speed. You just go down the list, entering the parameters, performance status, time to treatment, and those 5 key lab values. It's all simple yes or no toggles, which completely removes any guesswork. And boom, 1 click, and you get this unified results panel. Right away, you see both scores, the risk category it places the patient in this case, poor risk, and it even gives you a reminder of that median survival data. This dual view gives you a truly comprehensive, evidence-based picture in a matter of seconds. But how can you actually trust the numbers coming out of the machine? This part is absolutely crucial. We don't believe in black boxes. The math and the reference tables are right there for your review. So when you click Show Logic, it reveals the exact data underpinning the calculation. It links you right back to that reference table we just looked at. This makes the entire process completely transparent and proves that the output is directly traceable to the original studies from Heng and Motzer. Okay, so the tool is fantastic for an individual patient, but its utility goes way beyond that. It's also designed to bridge the gap between a clinical decision and a powerful research engine. See this Save All Results button at the bottom? That's your first step. With just 1 click, you capture that entire data set, all the inputs you entered and the scores the tool calculated for that specific patient. Every patient you save gets compiled into the central list. Then, whenever you're ready, that Export All to CSV button packages the entire cohort into a single, clean, flattened CSV file. It's perfectly structured to drop right into any statistical software for your academic research. And that CSV file, it isn't the final destination. Think of it as the entry point into a full research ecosystem that's designed to take you all the way from raw data to real discovery. The workflow from here is just a simple 2-step process. Step 1, you prepare your data, make sure it's clean, formatted correctly. Step 2, you run the analysis. You just upload that polished file to generate your survival curves automatically. And here's what that workflow looks like in action. On the left, you've got the CSV Polisher. It's a tool specifically built to help you clean up your research data, handle missing values, and get it ready for analysis. Then on the right is the Survival Analysis tool. You just upload that clean file and you're ready to go. And the result? The tool automates all the heavy lifting of your research. We're talking streamlined chi-square analysis, publication-ready Kaplan-Meier curves, and all your log rank stats and hazard ratios calculated for you. It turns that clinical cohort data into powerful insights, so much faster. So that really brings us to the final question. When you can seamlessly move from guideline-based clinical stratification directly into a fully automated research workflow, how much of your valuable research time could you get back?